afternoon, everyone. I want to thank you, Omics International Group, for inviting us here. Today, my topic is Sentinel lymph node biopsy enough for axillary macrometastasis? You know, there are 3 randomized control studies in this topic. One of them is Z11 trial. One of the most famous and the oldest one is Z11. Z11 had both micro and macrometastasis. And the second study is International Breast Study Group trial. It included only micrometastasis. And the last one is Amaros trial, had both macro and macrometastasis. So the first trial is Z11 trial. This is only patients with breast conserving surgery. All patients had early stage breast diseases, T1 and T2, clinical and zero diseases, found 1 to 2 positive sentinel lymph nodes. Again, 40% of them had micrometastasis and 60% of them had macrometastasis. The question is, the randomization is axillary lymph node dissection versus sentinel lymph node dissection in the breast conserving setting and breast radiotherapy. Median follow-up of 6 years, 5-year overall survival, and 5-year disease-free survivals are all identical for whole groups. When we look at the Kaplan-Meier curves, again, there is no difference between the group. And the group said that there is no need for axillary lymph node dissection, sentinel lymph node dissection is enough treatment if the breast is conserved and if there is breast radiotherapy. Although arguably this study is very practice-changing, at least practice-questioning study in the breast world from radiation oncology perspective, we don't know the details of radiotherapy fields. Second study come from International Breast Study Group. This is the study, both breast conserving surgery and 9% of them had mastectomy. T1 and T2, again, same patient population like Z11, but only micrometastasis. Isolated tumor cells also included this study. The question is same, the randomization is same. Axillary lymph node dissection versus sentinel lymph node dissection is compared, is randomized, and there is no difference between groups. And the groups say, again, there is no need for macrometastasis, and sentinel lymph node dissection is enough treatment, at least for breast conserving surgery and radiotherapy. When we look at Sentinel 2013 consensus, the experts said that if you had a 1 to 2 positive sentinel lymph nodes and the breast conserving surgery plus breast radiotherapy, yes, there is no need for full axillary clearance. 73% of the experts said that the axillary lymph node dissection is not necessary for those patients. But at the end of the 2013, we learned that the radiation fields of Z11 trial, at least 1/4 of them, we just know the 1/4 of them. And we saw that there is some lymphatic radiation also in the Z11 trial, both axillary lymph node dissection arm and sentinel dissection arm. Interestingly, there are some supraclavicular field, even posterior axillary boost is used in the Z11 trial, at least 1/4 of them we know. This is a major protocol deviation if you look at the original Z11 protocols. Again, this is breast-only radiotherapy. This should be the case when if you say Z11 is say this, they are treating like that. But we learned that there are some high tangents. Of course, level 1 and level 2 is treated. Even supraclavicular fields, it's not allowed in the protocol. So 60% of both arms in the Z11 trial received some form of lymphatic radiotherapy. And then the Amaros trial come out. Amaros trial has both breast conserving surgery and 17% at mastectomy. Again, early breast cancer patients wanted to positive sentinel lymph nodes. It's very similar to Z11 population, both macro and macrometastasis was there. But the question is somewhat different from other two trials. The question is, the randomization is axillary lymph node dissection versus axillary radiotherapy. The 5-year axillary recurrence rates are almost identical, and there is no difference between the groups. And the Amaros trial said that axillary radiotherapy with less toxicity could be chosen. And extracapsular extension. We are still looking at extracapsular extension. We know that it's prognostic even for local regional recurrence and even for distant metastasis. We're still looking at, especially if we have a patient with only sentinel lymph node dissection, there is no axillary dissection, we're still looking at this parameter. But gross extracapsular extension is not included in Z11 trial, also in international breast cancer study groups trial. But the Amaros trial, it is not evaluated, perhaps due to, anyway, they did axillary surgery or axillary radiotherapy, and they just don't look at if there is extracapsular extension or not. I think it is an important prospective study come from Memorial Sloan Kettering. This is the Z11 patient population. They just look at with and without extracapsular extension. There is an additional 4 or more node positivity is higher in the, if there is extracapsular extension, 20% had 4 or more positive lymph nodes in axillary dissection. Further dichotomized the extracapsular extension, 2 millimeters less or 2 millimeters more. It's still important. There is a significant difference between more than 2 millimeter extracapsular extension, and 1/3 of cases had 4 or more not positive axillary lymph node dissection. What about the patient with mastectomy? We know international breast cancer study group, only 9% of patients had mastectomy, and post-mastectomy radiotherapy details, unfortunately, is not reported. And the Amaros trial, 17% of patients had mastectomy, and 1/4 of them in axillary lymph node arm, and 40% in axillary radiotherapy arm received chest wall radiotherapy. What about the toxicity of trial? In international breast cancer study group trial, less sensory motor neuropathy and less lymphedema with sentinel lymph node dissection is observed. Also in Amaros trial, less lymphedema, but a little bit more shoulder impairment with radiotherapy is reported. When we look at all together, all this trial, Z11 trial is the both micro and macrometastatic cases had extracapsular extension is not included. Randomization is axillary lymph node dissection versus sentinel lymph node dissection. Regional control are almost same, but regional radiotherapy, we learned that later regional radiotherapy may contribute to both arms. When we look at international breast cancer study group trial, it is only micrometastatic cases. Macro 1 is not included. The question is same as Z11, and the results are both same. And of course, the sentinel lymph node dissection is a less toxic treatment. And when we look at the MROs, this is look like the Z11 trial patient population, but the randomization is somewhat different. Lymph node dissection versus axillary radiotherapy, and the results are both are same, but less lymphedema with axillary radiotherapy. If the question is still, if is sentinel lymph node biopsy enough for axillary macrometastasis, the answer is yes for breast conserving surgery, but for mastectomy, individual decision making should be done. Is sentinel lymph node biopsy enough for axillary macrometastasis? The answer is no. We suggest that do not use frozen section during sentinel lymph dissection. Avoid unnecessary axillary lymph node dissection. And axillary lymph node dissection and axillary radiotherapy have equal result, but less lymphedema with radiotherapy. What about radiotherapy fields? If gross extracapsular extension, in example, more than 2 millimeters, we still discuss both with surgeon and patient go to axillary lymph node dissection if there is gross extracapsular extension. If we have no gross extracapsular extension and patient with luminal A diseases with 1 to 2 positive sentinel lymph nodes, breast plus high tangents, we suggest that, and level 1 to try to irradiate to level 1 to. If we had a non-luminal A patients, of course, no gross extracapsular extension, non-luminal A patients with 1 to 2 positive sentinel lymph nodes, breast plus, supra plus, level 1 to 3 lymph nodes radiotherapy. Mammary internal radiotherapy could be considered in the light of MA20 and mammary internal trial just 2 weeks ago. That was published in New England Journal of Medicine. And mastectomy patients, still individual decision making should be done. When we look at Sengel and 2015 meeting, the question is, macrometastatic 1 to 2 lymph nodes, can axillary dissection be safely omitted? If mastectomy and no radiotherapy planned, all say no. If there is mastectomy and radiotherapy planned, say half-half yes and no, but as I mentioned, this is, I think, mostly opinion-based. Conservative resection with radiotherapy using standard tangents, this is the same question of 2013, and two-thirds of them say that it is enough treatment. But the question come to like that, conservative resection with radiotherapy using high tangents to include lower axilla, it's about 100, they say yes. I want to thank you for your attention.
The next speaker is Nikolai Bakalbasa from the University of Medicine and Pharmacy, Romania.